Dr. Arnol Caplan. Es considerado el pionero en la investigación de células madre mesenquimales en el mundo. Graduado en ciencias en el Illinois Institute of Technology. Es profesor en ingeniería biomédica y director del Centro de Investigación Esquelética. Fue premiado con el Lifetime Achievement Award por el International Joint Preservation Congress. El Dr. Arnol Caplan es uno de los ponentes en el segundo Simposio Internacional de Células Madre.
Hello, amigos. So first I have to apologize. I only speak English. I speak English badly. I'm jealous of all of you in the audience who speak 2 or 3 languages. So I immediately apologize for not giving my lecture in Spanish. It's in the United States, we're lucky if we learn English. So I'm going to do 2 things. One is I'm going to give you the background and science about MSCs, but one of the things that I'm going to beg you to not do is to call MSCs stem cells. And I'm going to show you the data which says they're not stem cells. And the idea of a physician who injects stem cells into a knee of an osteoarthritic patient is that those cells are going to go in and make new cartilage. So this never happens, and I'll show you the reasons. Why. So these are my obligatory disclosures. I started a company called Osiris Therapeutics. I have nothing to do with Osiris. The university gets royalties, which they very generously share with me, which won't buy the coffee that we're all drinking this morning. So you don't have to worry about me retiring on my royalties from Osiris. I'm also a consultant for Lipogens. You'll see why. So I always like to be a little controversial. So I'm going to tell you that young women have monthly bleeds, but never get sepsis. If I had a bleed like that on my arm, I would run to the emergency room and I would not worry about scar tissue, I worry about infection. So I can assure you that the uterus is not sterile. So why do women never get sepsis? So I'll give you the answer during this lecture. So in 1991, I wrote this article, and I called the cells that I was working with from bone marrow mesenchymal stem cells. And I did so for the right reasons, and it only took me 10 years to convince the orthopedic industry that there were MSCs in marrow, and now everyone accepts that they're stem cells. And in 2010, I wrote an article to change the name. So I have this very delicate ego, so I want everybody to continue to use MSC nomenclature, but MSCs are not stem cells. They're medicinal signaling cells. They make drugs at sites of injury, and I'll show you that data. So here's the conclusion of my lecture. So if you want to go to sleep or take your earphones off, you can do so after you read this slide. So MSCs, as Diego said, come from perivascular cells, from pericytes. They do not come from stroma. Stroma is an old anatomical term for connective tissue. MSCs do not come from connective tissue. They come from perivascular cells. They also do not differentiate into cartilage or bone or other mesenchymal tissues inside the body. What they do inside the body is make drugs at sites of injury. Those drugs can control the immune system, and they can set up a real regenerative microenvironment for the tissue to naturally regenerate. And what you do as physicians is you manage the innate capacity of the patient to regenerate tissues, fix tissues. That's your job. The MSCs do this naturally and assist in this job. And some of the completely unpredicted pieces of science in the last few years is that MSCs make molecules that sit on opioid receptors and manage pain. And I'll show you the data for this. And also they make molecules which kill bacteria, antibiotic proteins. So MSCs are not stem cells. What we saw with marrow MSCs was that in vitro, on a petri dish, I can make cells dance. And so I get them to dance into muscle or dance into cartilage or dance into bone. They do not dance. They do not do that dance in the body because I'm not there to orchestrate the routine. It's as simple as that. We know tricks for tissue culture. Your body does not use those tricks. So the MSCs do other things, and what they do is they function to manage your own ability to regenerate tissue. All of you are alive because you continually regenerate your tissues. Cells die, they have half-lives, and you regenerate those cells. And this is the example I always use. Every single second, 15 million blood cells in your body drop dead and are perfectly replaced. So while I said that sentence, 200 million cells in your body dropped dead and were perfectly replaced. No one raised their hand and said, I'm super person, I can regenerate millions of cells. You do this naturally because in your bone marrow, there's this cell which is called a hemopoietic stem cell. If you have radiation or chemotherapy and it kills this cell, you will die. You will die because the cells in your bloodstream are going to die on time and they're not being replaced. So bone marrow transplantation 50 years ago was initiated for these cancer patients to give them back the hemopoietic stem cell. So those of us in orthopedics, of course, we deal with bone marrow. And so in bone marrow, there's another cell, which I call the mesenchymal stem cell, and I drew this diagram as a hypothesis slide in the late 1980s. And this slide was immediately criticized by my esteemed scientific colleagues because it was well known, that means the dogma of the day, was that you only had one stem cell in your adult body, and that's the hemopoietic stem cell. That dogma is wrong. I'll show you a slide in a minute, but what I drew on this slide was the mesenchymal stem cell at the top. In tissue culture, I could drive it down this lineage to make bone, or this lineage to make cartilage, or the next lineage to make muscle. All tricks of tissue culture. And if you want to do tissue engineering, you need to know these tricks. So your ear cartilage, your nose cartilage, your throat cartilage, your hip cartilage, your knee cartilage, your ankle cartilage, all different. Nobody can take an MSC and drive that cell into a knee articular cartilage phenotype. We don't know the tricks to do that. We're working on it, and I'm actually funded to do that. But no one has been successful to do that. And that's the challenge for the tissue engineers. So I'm not going to talk any more about tissue engineering. I'm only going to talk about what's at the top. The MSC is your natural avenue to regenerate tissues. So this is real regenerative medicine. So for those of us who work on marrow, all of the tissues that are listed on the left side of the slide, there's publications that shows that you can get MSCs from every single tissue. I can't think of anything more, for someone who works on marrow, anything more disgusting than to think that you could get these special cells from fat. I mean, it's just horrible to think about that. Or any of these tissues, liver, lung. And what do all these tissues have in common? They all have blood vessels. And that's the trick that we missed in the beginning. So this is a fact, and so I'm going to tell you the end of the story and then show you the data for how we got there. So this is the slide that Diego showed from Bruno Pio. So when Diego took his blood pressure medication this morning, the little red cells on this capillary and heart squeeze together to give high blood pressure or relax to give low pressure. This is the mechanochemical arm of blood vessels, of small blood vessels. So blood pressure medication is targeted to pericytes, not to endothelial cells. Endothelial cells do not contract. The blood vessels do not contract. The outside of the blood vessel, the pericyte, contracts. So every cell you see in this slide is a pericyte. Every cell you see in the slide is a pericyte. Every cell you see in this slide is a pericyte. Every cell you see, are you getting sleepy? Did you notice that every picture of a blood vessel, the pericytes were different? The pericytes look different because they had their backs to different tissues. Every panel was a different tissue. So MSCs that come from pericytes, from liver, are going to be very different than those from marrow and very different from fat. And I'll show you molecular data to prove this. Do they function at sites of injury differently? No. An MSC is an MSC is an MSC. It's a hugely important point. So what I know how to do is to kick the MSC off the blood vessel, put it on a petri dish, and make the cell dance on a petri dish. That's been used as the definition for an MSC. That is wrong. That doesn't happen in your body, and that isn't the medicinal characteristics of MSCs. So MSCs on a petri dish are multipotent, they're stem cells, but in your body, not. So here's a paper. You need to read these papers. You can get copies of this from all the people who are taking pictures. And so this paper shows two things. One is, if you have a labeled MSC and you put it in culture, you can get the label will go into all those tissues. I can make cells dance. But if you have an animal that has labeled MSCs, this red pericyte, and if the animal's aging or on a high-fat diet, making huge amounts of fat, or you break its leg or you injure its muscle, the label never ends up in the tissue. That says that the MSC that comes off the injured blood vessel never differentiates in vivo. So you need to read this paper. So again, Here are all those tissues. What those tissues all have in common? Pericytes, blood vessels that are decorated. But what's the case and completely misunderstood 10 and 20 years ago is every tissue of your body has its own tissue-specific progenitor or stem cell. So you have a heart stem cell, a liver stem cell, a kidney stem cell, a skeletal muscle stem cell. All of those stem cells can be isolated, can be cultured on a petri dish, and they'll make, so cardiac stem cell makes cardiac muscle. Liver stem cell makes hepatocyte. Every stem cell, which I've put here as a yellow ball, is always sitting next to a blood vessel and is always sitting next to a specialized MSC pericyte. This is the case for every stem cell in your body. And so there's papers published to show that this is the stem cell niche. And I'll show you that this is the case in marrow and in other cells. So this changes the way you think about tissue regeneration. It has to be done one tissue at a time. And if you want new cartilage on your knee, you have to stimulate the chondrogenic stem cell that's in your knee. And even somebody as ancient as me, I have stem cells. I am alive, and my tissues continue to regenerate themselves. My arthritic knee's not so great, but my heart's perfect. So blood vessel breaks, and now you need to look at me for a minute. This microphone's a blood vessel. On the blood vessels, a pericyte. Blood vessel breaks, pericyte comes off, it differentiates, and from its front, locally, it makes a curtain of molecules. That curtain of molecules stop your over-aggressive immune system from interrogating the injured tissue. This is your first line of defense against autoimmune reactions from setting up. Because injured tissue has new antigens. If your immune system sees the new antigens, you're in trouble. Because that tissue will become reactive. From the back of the MSC, what happens is that it makes, MSC becomes activated, immunomodulation. From the back of the MSC, it makes a spectrum of different molecules. Those molecules are anti-scarring, angiogenic, bring in new blood vessels. They affect the tissue-specific stem cell to divide. So if you have a heart attack, there's cardiac myocytes that die. So you want new cardiac myocytes. So you want your heart stem cell to divide and make new cardiac myocytes. MSCs supply the information to tell that cell to divide. So this is setting up a regenerative microenvironment, which is what Diego said is the most important aspect of regeneration, that you have all of the molecules in the environment that help you regenerate. So if you go to this website called clinicaltrials.gov and you put mesenchymal stem cells in this search engine, there are 999 clinical trials listed in that website. And this is a picture of the United States. I'm hugely politically active. I hate red states, except this picture, all the red states are the states that have the most clinical trials with MSCs. And so, for example, Look at this state. This is Minnesota. First of all, in Minnesota, the winters are the most horrible winters you could imagine. You could walk outside and die within 2 minutes. Look how many clinical trials. Why is that? Minnesota. Who in their right mind would go to Minnesota for a clinical trial? Mayo Clinic is in Minnesota. Mayo Clinic has a regenerative medicine institute that has an MSc arm to it and does all these clinical trials. So the state that's the winner, of course, is Florida, because of all the people who speak Spanish, no question. So lots of clinical trials, and in Europe, the country that has the most clinical trials is Spain, because they're committed to MSc therapies. So again, these are all of the clinical symptoms. I just copy-pasted them onto the slide. No one can read them, so I'm going to do higher fonts. And so Crohn's disease, graft versus host disease, MS, ALS, all of the autoimmune diseases, because again, MSCs are your first line of defense against autoimmune disease. If you have autoimmune disease, maybe it's the MSC in your body which is the problem. So I want Diego's MSCs. Why do I want Diego's MSCs? Well, first of all, he's younger than I am. Second of all, the more important thing is his curtain works in my body. So my immune system won't see his MSCs. That means that not that his MSCs are immunoprivileged, they're immunoevasive. The curtain is hiding them from my immune system. Eventually my immune system catches up, but I can use allo MSCs, and if I have MS or I have diabetes, I want somebody else's MSCs, just because my MSCs may be the problem. Kidney transplants. MSCs are given with kidney transplants as a chaperone to guard against rejection. So now there's a clinical trial in China, 500 patients, no immunosuppression, only autologous marrow MSCs for these patients to help them with kidney transplants. Rheumatoid arthritis, lupus, there's a stage 3 clinical trial for acute myocardial infarct. So MSCs do not come from stroma. So you need to change your brain and think pericytes, because it changes the way you think about MSCs. So again, MSCs are not stem cells, and I call them, I prefer everybody calls them Caplan cells, but I can't get any of my papers published when I do that. So you have to call them something, call them MSCs, and I just changed the name because they're drugstores to medicinal signaling cells, just so you can keep the MSC nomenclature. So MSCs function at sites of injury. So when we put Diego's MSCs into my bloodstream, of course I'll be tickled with his wonderful cells going through my body, but those cells are going to dock at sites of injury, because that's where they normally do business. And when they dock at sites of injury, immunomodulation and regeneration and the management of my innate capacities to regenerate tissues. All of us have the innate capacity to regenerate every tissue in our body. How do you manage it? And MSCs are capable of managing it. So most people miss this hugely important point. MSCs go to sites of injury, and they're sensory. They sense the microenvironment, and then they have a response to that microenvironment. So if you have a stroke or you have a heart attack, you don't want the same molecules sent out. So the MSC knows it's in brain, or the MSC knows it's in heart. It has a different response profile, whether it comes from fat or it comes from bone marrow. The response profile is determined by its ability to sense the microenvironment, and it can sense the microenvironment several ways. It can sense it by actually touching other cells, or sending molecules out, or having receptors that sense it. And here's a paper that proves what I just said. You have the same blue MSC. On the left side, we give that MSC inflammatory molecules. So what does it do? It makes anti-inflammatory molecules. On the right side, we give it molecules that tell it it's going to see bacteria. So what does it do? It makes inflammatory molecules. Why? Because you want your hemopoietic system to send macrophage and monocytes to get rid of all those bacteria. If you do anti-inflammatory molecules on the right side, you die, because you'll have a massive infection. And you want the hemopoietic system to come and take care of those bacteria. So again, same cell, different signals, different response profile. And that's because the MSC senses the microenvironment. Everybody says, well, which molecule is the most important in the sensing? 100 molecules. It's a live cell. It's a live cell. So all those signals register and stimulate this response profile. So I'm going to talk about neuropathic pain. And this is a paper which I've referenced on the bottom. And what they do is they make a spinal cord injury, but there's 20 papers like this. The most important part of this paper is that marrow-derived MSCs or fat-derived MSCs in this model are equally potent, which is what I said. They see a microenvironment, screaming nerves, they have a response profile, whether it's from fat or whether it's from marrow. So it's the same response profile. So everybody bumps into a wall, and 2 days later you have a black and blue mark. What do you know? You broke blood vessels. So when you bumped into the wall, it hurts like hell for about 15 minutes. And then the pain goes away. Why? I told you. MSC comes out, broken blood vessel, looks around, sees the screaming nerve, and makes molecules that sit on opioid receptors. So the pain goes away because you broke a blood vessel. If you bump into a wall and you don't break a blood vessel, it's going to hurt like hell for 2 days. So again, MSCs function in neuropathic pain. This is my good friend, Dr. Chang, who's at the Cleveland Clinic down the street from my lab, and he snuck this abstract into his annual meeting of the American Academy of Pain Medicine. This is from 2015. What he did was incredibly important. He took mice and he habituated them to opioids, so they become tolerized. You and I can take opioids for 10 to 16 weeks, and then we become tolerized. And so if we still have the same pain, we take 2 more pills to increase the dose. So he tolerizes these animals, then he sneaks over to my lab down the street, steals some marrow MSCs, and puts them into the mouse. Human MSCs into mouse. How could that be? You were all taught that you could never put a human cell into an immunoreactive mouse, right? The curtain that the MSCs make works in mice or rats. So we can use preclinical studies, which are really preclinical. We take batches of MSCs and use them in animal models. So it's a real preclinical model. So in this case, he tolerizes the animals, gives them MSCs from marrow, and they lose tolerance. So low dose works again. The better experiment, the one I like best, is he gives the animal MSCs to start, and then he can never tolerize them. This is the first study to indicate that MSCs are making molecules that are sitting on opioid receptors. And this is a paper which was published in 2011, which everyone in this room, even the pain people, never read. This is a key paper. So there are antagonists to opioid receptors. So you give morphine, you give the antagonist, and it kicks the morphine off the receptor. That's what's an antagonist. So they take a mouse or a rat and they damage the TMJ nerve. So now it hurts like hell. So you touch the cheek of the animal, it goes through the ceiling. If you give it morphine, you touch the cheek of the animal, it's fine. Because the morphine is sitting on the opioid receptors, calming the whole thing down. You give it human MSCs, you can touch the cheek all you want. So this is an experiment with human MSCs, and you take the human MSCs and you give it to the animal, and this works for 22 weeks in this animal. The first 3 weeks, if you give the peripheral antagonist, it knocks the molecules off the receptors just like it's morphine. So you touch the cheek of the animal, it goes through the roof. If on week 5 you give the peripheral antagonist and you touch the cheek, the animal goes crazy. So the MSCs don't work peripherally, they work centrally. So now there's a mechanism by which the MSCs affect mu receptors in your central nervous system. How could that be? MSCs don't move across the blood-brain barrier. They don't go from your cheek to the brainstem. So I'm going to give you the answer for that in a few minutes. So this is a clinical trial, simple clinical trial. 10 female patients all have TMJ pain, horrible pain. They liposuctioned the patient. They got the stromal vascular fraction that Diego talked about, and they analyzed every one of the stromal vascular fractions, and the CD90 says that about 30 to 45% of the cells are MSCs. They gave these patients directly injected right into the trigeminal nerve field. Pain went away. So 7 out of the 9 patients, pain went away. So again, you need to do a bigger clinical trial. You need to show that this is statistically relevant, but this is exactly like the animal experiment. So there's 300-400 papers about MSCs for spinal cord, for any of the pain that you can imagine. MSCs have been tested in clinical models, and for many of the spinal cord problems, and indeed for the treatment of patients with MS, the MSCs have been given in the spinal cord intrathecally. How many times has a resident in the emergency room done a spinal tap? If you can do a spinal tap, you can give MSCs intrathecally. Don't go home and try it. Practice first. But again, if you have a central nervous system problem, Don't give the MSCs in the blood. It doesn't do anything. So MSCs control pain by making molecules that sit on opioid receptors. Those molecules function peripherally and then eventually centrally. So I'm going to address the central question now. So again, whether it's trigeminal nerve or you have a heart attack, how do you get long-term therapeutic effects from MSCs? So this is a paper which has recently been published. They take human MSCs that are labeled and they give it to a mouse. 24 to 72 hours later, the MSC's gone, but the MSC's labeled. The label ends up in a monocyte which is marked by LY6C low. The monocyte has eaten the MSC in the lung or in circulation. That's where those monocytes are. So the label is in the monocyte. When that monocyte eats the MSC, it changes its cell surface markers to become CD206 and CD163 positive. When that cell bumps into a T cell, it converts a T cell to a regulatory T cell. So nobody's going to remember this paper or go read this paper. I know that. So I did this cartoon. So this is a monocyte, LY6C low. It sees an MSC, it eats the MSC, and it becomes instructed by the MSC. It had the MSC for lunch, feels full, changes its cell surface markers, and when it bumps into a T cell, it breathes on the T cell and converts the T cell to a regulatory T cell. Regulatory T cells stay in your body for years, and they cross the blood-brain barrier. So if you want to have a molecule or a cell, a regulatory T cell, that can stay for a very long time, regulatory T cells can shut down the immune system. Regulatory T cells can provide long-term therapeutic outcome. They cross the blood-brain barrier. They're the candidates for neuropathic pain. So again, long-term therapeutic effects by MSCs are not from the MSCs themselves, because the MSCs are gone. So they're secondary and tertiary mechanisms that we basic scientists have to continue to describe so that we can understand long-term therapeutic effects. So this is Tracy Bonfield. She works across the street in Rainbow Babies and Children's Hospital. So in this hospital, they're very famous for dealing with kids with cystic fibrosis. So cystic fibrosis is a mutation in a very powerful transmembrane conductance regulator. This regulator regulates sodium-potassium transport across membranes. So these kids have horrible mucus on their lung, mucus in their GI tract. And so, for example, the mucus on the lung, they have horrible, horrible lung infections. If you get a lung infection and you have Pseudomonas, these kids die from Pseudomonas because we don't know how to treat Pseudomonas. We don't have an antibiotic for Pseudomonas. So what the experimentalists at RBNC did is they got mice and they took the transmembrane conductance regulator out, knocked it out of the mice. So they call them CF mice, knockout mice. So we take an agarose bead, we put Pseudomonas particles in the bead, and we put the bead directly into the lung. Normal animal, huge lung infection of Pseudomonas. 7 days later, infection's gone. Animal walks away, no problem. If you give the same agarose bead to a CF knockout mouse, within 7 days, every animal is dead from the infection. Like kids, can't handle the infection. If we take Diego's marrow MSCs, and on day 2 of the infection, we give the mouse human MSCs, mouse walks away. How does the MSC work? So we spend 6 months trying to figure out how the immune system did this fabulous thing. Wasn't the immune system. MSCs make a molecule which is called LL37. LL37 kills bacteria on contact. Every single person in this room, even the guys trying to sleep in the back, you're making LL37 in your mouth, and it's what controls the bacteria load that's going to your GI tract. So MSC bumps into a bacteria, makes LL37, kills the bacteria on contact. These molecules have been studied by oral biologists for 30 years. When your animal hurts its paw, when the cat or the dog hurts its paw, they lick the paw. You think they're cleaning the wound. They're putting a layer of antibiotic proteins on there. They're called, don't you try it because your mouths are dirty. Animals survive because they know how to take care of themselves. Take a wound and put antibiotic proteins. Your mother taught you when you stick a needle in your finger, you squeeze the blood out, right? You squeeze the blood out. Why do you do that? Your mother said to clean the wound. Guess who's sitting around the hole just waiting for a bacteria to walk in? They're called MSCs. Because if a bacteria tries to get in that puncture wound, makes LL37, hello, goodbye bacteria. So I just answered the sepsis question. What is a bleed? A bleed is a broken blood vessel. Broken blood vessel. Multi-millions of MSCs in every monthly flow. And this is an advertisement from an Indian newspaper. For a few rupees, they'll collect menstrual flow, they'll isolate the MSCs, and freeze them down for emergency use. And there's 100 papers that show that menstrual MSCs are just the same as marrow MSCs, are just the same as fat MSCs. An MSC is an MSC, is an MSC. Menstrual flow, broken blood vessel. Broken blood vessel, MSC. So you have to think pericytes. So again, MSCs function at broken blood vessels. They make drugs, and those drugs manage your ability to regenerate tissue. For menstrual flow and for viral infections, MSCs try to protect your tissues from invasion. It's what the MSC does. Surveys the microenvironment. If it sees bacteria, has a response profile. If it sees virus, it has a response profile. So if you have a broken blood vessel, you have a response. Now, I'm not going to, because of time, I'm not going to go through this, but you have to understand that all the companies that make MSCs, every batch of MSCs, Diego's MSCs, every batch of MSCs has different potencies. And so, for example, there's a company called Mesoblast that has 5 or 6 phase 3 clinical trials, now listed on clinicaltrials.gov. The same production run of MSCs for graft versus host disease, acute myocardial infarct, for low back pain, for diabetes, same production run. So the MSCs are not tuned to the disease that they're being used for. So you expect some people not to respond. Likewise, I may not like Diego's MSCs in my body. So I have a response to the MSCs that also is not tuned to the MSCs that are being put into me. So you're going to get a high level of non-responders, which is what we talked with Laura about. So it turns out that in the Mesoblast low back pain clinical trial, phase 3, they have 3-year outcomes that are fabulous. More than half of the people treated, no response. Why is that? Every drug on the market, whether it's over the counter or by prescription, has at least a 30% non-responder rate. Does the drug company want you to know that? No. So if Diego has a headache and he takes Tylenol and Tylenol doesn't work, he's a non-responder. Tylenol works for headaches, no question. That's what it was first approved for. So again, non-responders in untuned cell preparations means higher non-responders. And what Diego said to you is tuning with pre-incubation with IL-1, gamma interferon, and TNF-alpha to get the cell used to seeing a highly inflammatory environment is one way to try to put MSCs into a body of somebody who has, for example, rheumatoid arthritis, because that's what the cell is going to see. So I'm going to quickly go through the question. In the early days of this technology, as indicated by Bruno Piot's slide, is that if you sort for CD146, you get a homogeneous preparation. And all of the MSC markers are Gaussian distribution. So we said, when we saw that it's a homogeneous preparation of MSCs. That's completely wrong. And this is a paper which I reference, which you should go read, a brand new paper. I'm only going to show you 2 pieces of data from this paper. One is, here on the bottom, in red is fat-derived MSCs, and in blue is marrow-derived MSCs. They have 17,000 transcripts in common. But each of them has about 1,500 transcripts which are unique to those cells. Remember, a fat-derived MSC, a marrow-derived MSC are different. And this is called principal component analysis, and so every preparation of multiple preparations of marrow MSCs or of fat MSCs were analyzed. And what you see is there's no red dots where there's blue dots, and there's no blue dots where there are red dots. So they're distinctly and uniquely different. And again, they have the same response profile, but because of all of those transcripts in common, but they're distinctly different. And this is, again, marrow MSCs. And what I want to point out, this is called RNA-seq single-cell analysis. And what they showed is you have all of these different kinds of MSCs that are grouped by different colors. And what you see is colors. I don't know if you can see this up here, but each column is a different color, which means it's a different subset of MSCs. And what you see is each of them has 5 to 10 different transcripts which the other one is not making. So each subset of MSCs, and in marrow there's probably 10 to 15 different subsets, they're making different molecules. So again, which MSC is the most potent? Which is the MSC which works for people with MS? Which is the MSC that works for osteoarthritic knees? We don't know the answer, but they're hugely different. So this is the the tissue that most people are interested in is fat. And I want to point out in these pictures. So this picture, it looks like fat's homogeneous. Fat's not homogeneous. That makes sense, right? Fat's not homogeneous. The cells that are sitting here and the cells that are sitting here are seeing a different microenvironment. Although fat is beautiful, because every single adipocyte has a capillary that nurtures it. And so therefore there's 300 to 500-fold more MSCs per cc of fat than per cc of marrow. 300 to 500-fold because there's more capillaries. So this is a paper which was published in Science this year, and what you see is there's 10 different kinds of MSCs in fat that come from fat by different colors. And what they did is they identified unique molecules in each one of these separate groupings of MSCs. And the smartest thing they did, just genius piece of science, is they took those unique transcripts that I showed you in the slide before, and they made probes to those. And those probes, they light up different anatomical regions, which is exactly what I just said. The MSCs from one region of fat see a different microenvironment than another region of fat. And so therefore they have different molecules. And we now can identify them morphologically, and we can pick them out of, by those molecules, we can sort them out of the pack. So again, the science of MSCs is going to get highly boring, highly technical, and the object is to get the best cell for the right clinical function. So again, many companies doing MSCs. I'm going to talk quickly about lipogens because in this case, this is approved by the FDA for osteoarthritis. And what you do is you take a liposuction, you put this liposuction into this tube. The tube has in it saline. The genius of this rig is the input port here has stainless steel wires that are crisscrossed, and so it further disrupts the lipoaspirate. Then inside the tube that's filled with saline, there's stainless steel balls, and you shake it for a couple of minutes like you're making a martini. We can really identify the good martini makers from this technique. And the balls further mechanically knock the pericytes off. So then you open up this stopcock, you put in new saline, and what you do is all of the busted cells, all of the fat, all of the debris, all of the monocytes go into the garbage bag, and you accumulate live adipocytes with intact blood vessels still from this preparation, and you collect them in a syringe. And the other genius of this apparatus is the exit port has 500 micron holes. So what you get is a ball of live adipocytes with the MSCs inside. How do I know that? Because I've taken these balls, put them in culture. Remember, I make cells dance in culture, right? So these balls never sit on the bottom of the culture dish because they have, each of the cells has fat in it. It's adipocyte. So the balls float. 5 days later, on the bottom of the dish, MSCs. So you could get purified MSCs from this preparation, or you can put this ball into your osteoarthritic knee, and 5 days later, after all of the response to the injections have died down, the MSC comes out and says, what's going on here, and does its job. So it's a slow release vehicle for drug-making cells. And this is, again, very simple preparation. We teach members of the orthopedic community to do liposuctions. They hate it because they don't like plastic surgeons, but it's easy enough to do even a 25 ml needle liposuction, pretty easy to do. So again, MSCs are not stem cells. They're drugstores for sites of damage. Drugstores for sites of damage. And I'm not going to go through the data, but as Diego said, we know what the chemistry is for what attaches the MSC to the basement membrane around the blood vessel. The molecule that does that is PDGF-BB. PDGF-BB anchors the MSC. So when you take platelet-rich plasma, platelets have a ton of PDGF-BB in them. When you break the platelets for PRP, you're just injecting a ton of PDGF-BB. You're releasing the MSC in the synovial lining. You're activating it, and it does its magic. So PRP in people who respond is, you could say it's an MSC therapy, it's PRP. PRP, the molecules in PRP get the body to respond in a positive way, however that works. So again, MSCs are medicinal when you put them in. And again, this is my original hypothesis slide. What's wrong with this slide? What's wrong with this slide is we didn't ask the right question. We were told by the hematologist that MSCs came from stroma. Wrong. If you have stroma in your marrow, you have a horrible connective tissue disease. There's no stroma in marrow. There's perivascular cells, and that's the key. So remember MSCs. MSCs are not stem cells. Say that in your sleep. MSCs are not stem cells. They're medicinal signaling cells, and you need to think in a new way because this is a new technology, adding a live cell that can sense the microenvironment and has a response profile. So the conclusions are, MSCs come from perivascular cells. They inhibit scar formation. They modulate the immune system. They provide an immunoevasive curtain so that you can use allogeneic MSCs. They make molecules that sit on opioid receptors and manage pain. They secrete molecules that are angiogenic. They make antibacterial proteins that kill bacteria on contact. They make mitogens that make your tissue-specific stem cells, progenitor cells, divide and make new progeny. They survey, sense, and respond to different microenvironments in different ways. They secrete pro- and anti-angiogenic molecules depending on the microenvironment. MSCs are eaten by a class of monocytes in your body which then become instructive. I think an MSC is just a big exosome, just a bigger lunch that instructs the monocyte, and regulatory T cells are derived from that, and they can provide long-term therapeutic outcome. And the most important result is MSCs are not stem cells. So I think this is going to change the way medicine's practiced. Somebody in rural Mexico has a heart attack. Helicopter comes and picks him up if he's rich, takes him to Guadalajara where the cardiac guys deal with him. 10 years from now, that guy is going to get into his limousine, go a mile down the road to the medical center, and from the freezer, take a bag of Diego Correa's cells, MSCs, put them intravenously, and that will be the therapy. And there's a phase 3 trial by Mesoblast, which will finish this year, and I'm betting the data shows that. So that will change the way medicine's practiced. So Diego without a beard and Rodrigo Somoza and I made this poster for Nature. So you can download the poster at that website, doesn't cost anything. And this is a page from the standard medical textbook. And you always see marrow represented this way, where the hemopoietic stem cell that gives rise to all of the blood cells is represented here. But if you notice, gee, that hemopoietic stem cell sitting next to a pericyte sitting on a blood vessel, that's what I told you, right? That's every stem cell, every tissue-specific stem cell is sitting next to a specialized pericyte, MSC pericyte, and they're both in contact with that piping. So here's the picture that Diego showed, and I'm going to spend 2 minutes on it. This is a quiescent hemopoietic stem cell. This is an active hemopoietic stem cell. They're sitting next to MSC pericytes. Those MSC pericytes have different cell surface markers because they're making different molecules for those hemopoietic stem cells. If you want a hemopoietic stem cell to be quiet or you want it to be active, you have to give it different signals. The MSC pericyte is controlling the hemopoietic stem cell, has different cell surface signatures, and so we could sort those guys out and prove to you they're making different molecules. Also, in marrow is a different MSC, which has a different signature. It's already in the osteoblast lineage. So when you use marrow for a fracture repair, that's the cell that divides and responds and makes new bone. Not this guy, not this guy. So again, in marrow, in fat, in liver, in brain, there's pericytes that give rise to MSCs. The anatomical location means they make different spectrum of molecules. I'm not going to go through this, so download the poster. And again, I think my forecast is MSCs are going to change the way medicine's practiced. We teach a course in Cleveland. You're all invited to come. I can't pay for travel or hotel, but if you email me, I'll give you free registration if you say you went to this meeting. So again, May 12th to 14th, I invite people in to talk about hemopoietic stems, to talk about mesenchymal cells from fat, from marrow, neural stem cells. All of the, quote, stem cells are discussed. And in the afternoon, one afternoon, we do videos, and we take you to a lab and teach you how to do marrow MSCs and show you what the assays are. This is my favorite quote from Winston Churchill. Finally, we're at the end of the beginning of cell-based therapy. I think we're out of the lag phase. We're into the use of these cells therapeutically. They've been approved in Europe. They've been approved in Japan. They're going to get approved in the next 18 months for 2 or 3 indications in the United States. And I hope that this activity in Mexico reproduces what Laura described in Italy, because data is power. The more data, the better, and that's what we need, and we need all of you to report outcomes. If the outcomes are not good, we need to know it. If the outcome, if it doesn't work, if the non-responders is 90%, we need to know why. Guys like me need to figure that out. And so your job is do the therapeutics, send us the data so that we can make it better. And that's the job that we like to do at the Skeletal Research Center. It's clear there's lots of people who provide the data at the Skeletal Research Center. It's clear that I'm just the front man, the mouth of the center. Thank you.
Agradecemos la presencia del Dr. Arnol Caplan. Dr. Arnol Caplan, thank you so much for your conference. Y abrimos una sesión de preguntas para todos los asistentes. Por cuestiones de tiempo vamos a reducir un poco las preguntas y damos oportunidad después a que pregunten. Comenzamos por este lado.
So I'm going to let Diego be my translator.
Thank you, Dr. Caplan. Amazing, really amazing your talk.
Thank you.
I have a question about the therapeutic ways for the AMC. You say intrathecal, for some reasons, will be the best. There is another possibility to put this AMC intranasal through the lamina cribosa to arrive and diffuse in the tissue?
So there's a paper published around 3 years ago, which there's a paper published 10 years ago, which shows that people with Alzheimer's or older people have very low glucose, have very high glucose levels in the cerebral fluid. So it turns out everybody who can taste or smell, in the top of your sinus, you have holes in your head and nerves are coming through into the upper sinus. That's how you smell and that's how you taste things. So now there's holes in your head, and so there's liquid that goes from the upper sinus all the way across your brain and empties in the base of your brain here. So people at University of Minnesota, a guy, noticed this on MRIs, and he decided the high glucose levels means our brain cells are being starved. So his idea was to sniff insulin. Insulin would go to the cell surface receptors, the glucose would go inside the cell, and there's a phase 3 clinical trial for Alzheimer's patients which shows higher cognitive scores. So getting that glucose out of the liquid into your brain cells is hugely important. The same group with collaborators in Germany took rodents and sniffed human MSCs. Human MSCs go into this river that's flowing, and they report dramatic changes in neural activity. So which is better, sniffing MSCs or interthecal? Data. We need data. We need data. So the current reported positive aspects for MS are interthecal administration. No one for MS has tried the nasal passage. Getting a product approved for nasal introduction is a nightmare. Is a nightmare because you can measure dose of drug, but how do you measure dose of cells that actually get into the river? So it's going to be a long time till we sniff MSCs, but I'm for sniffing. MSCs is certainly better than having some resident stick a needle in my spinal cord. So this upper sinus is an entry route to this river that naturally flows across your brain. So it's one of the ways in which you may be able to do cell-based therapy. Data, we need data, and first animal models.
And what about the mannitol? To put in intravenous to open the barrier hematoencephalica?
I'm sorry, I didn't understand.
When you use the mannitol 20%, some papers they say they open your barrier to
Yeah,
pass.
again, in order to use nasal route, you have to show that you can access this river. So there's data which shows that older people who lose their sense of taste and lose their sense of smell no longer have this river flowing. So they're not candidates for this. But it depends. There's older people who have perfect taste and perfect smell. They're candidates for introducing drugs into this river. So it's not that my taste buds are excellent, so I haven't lost the holes in my head yet, but some older people definitely lose this ability to deliver drugs nasally.
Bueno, muchas gracias por su plática. El asunto, tengo dos comentarios. Uno, sí se habla del Alzheimer como una diabetes tipo 3 desde hace ya rato. Y la otra es con respecto al dolor. Me había comentado del dolor en la disfunción temporomandibular, que es lógico que haya una recepción, receptores de tipo MU a opioides. El asunto es que el otro de los estudios que presentaron era sobre neuralgia del trigémino, que no necesariamente actúan los opioides en ese caso. Algunos como el tramadol tienen acción interesante ahí, pero normalmente los opioides no funcionan en dolor neuropático. Y bueno, me llama la atención que los estudios es sobre dolor neuropático, ¿no? Donde el receptor MU no tiene técnicamente.
So what he's saying is that in trigeminal neuralgia, the mu receptors normally don't work as good as in the TMJ neuropathy. So, but there's been some data showing that you could eventually use opioids for neuralgia of the trigeminal nerve. What is your take about that?
So again, I can only tell you the data that is published. So the 10 females who were part of this study for trigeminal nerve had stromal vascular fraction, autologous stromal vascular fraction, injected into the trigeminal nerve field.
Okay.
So it was a direct injection, it was not systemic. So again, all of the results are direct injection. Remember, stromal vascular fraction, very heterogeneous population of cells. We don't know that the MSCs were the active agents. All we know is the 7 out of 10 of those ladies had scores that went from 9 to 1. So regardless of which cell did it, if I had trigeminal nerve, I would want a cell-based preparation, because as you know, you put opioids, you put morphine in the trigeminal nerve field, doesn't work so well. Yeah, so that's the issue. And so that's why I show that clinical trial, because it's unanticipated by the people who are in pain management.
There was a guy there.
Dr. Caplan, I'm Dr. Rios from Mexico, and I give you the welcome and thank you for sharing your knowledge with us.
My pleasure.
North of my country, we have a small clinic and we're treating people with cancer. So the obligated question is what's going on with the big C? Do you have anything about it?
Well, so right from the beginning of the MSC therapy with Osiris for the very first clinical trial, human clinical trial. If you have a history of any solid tumor, you were not a patient for MSC therapy. And now there's very good data to show that MSCs go to solid tumors and increase the rate of division of the cancer cells. So MSCs are wonderful, but not so good for cancer, not so good for solid tumors. And why is that? Because all of the solid tumors, the blood vessels are called leaky, right? That means the MSC sees those vessels as injured. So it goes to those vessels, and then it gets perverted by the cancer cells to make drugs to let the cancer divide at a higher rate. So people who have solid tumors, not candidates for MSC therapy. So what happens if you have a heart attack, acute myocardial infarct, but you have an undiagnosed prostate tumor? Well, you don't know that you have an undiagnosed tumor. So you get MSCs, and pretty soon the tumor is bigger. So you treat the patient with what's wrong. It could have negative side effects. On the other hand, people are now testing MSCs with solid tumors to deliver suicide genes that will kill the tumor cells. So again, it's not a standard procedure. I don't know that I would want that done with me, but the current CAR T technology is to train your immune system to attack tumors or cancers. So cell-based therapy for cancer therapy is already here, not MSC therapy, not MSC. So again, if a patient has a history of solid tumors, not a candidate for MSCs. I can tell you one situation. 5 or 6 years ago, I went to a meeting in South Korea, and they showed women with breast cancer who had their breasts removed, but they used autologous fat tissue supplemented with the autologous MSCs to rebuild the breast. I worried, but so far, at least the data from that clinical trial, those clinical trials shows no adverse events of using the extra MSCs. I would be nervous. So again, solid tumor, history of solid tumor, not a candidate for MSC therapy.
And what about when the patient is declared free of cancer?
Well, if the patient's free of cancer, I think you can, again, acute myocardial infarct, low back pain, graft versus host disease, which is a cancer patient, diabetes. There's a bunch of clinical symptoms that are now being tested for the medicinal properties of MSCs. So we'll see what happens when those clinical trials come out.
Sure, thanks a lot.
You're welcome. Yes, sir.
Hello, thank you very much for your lecture. I actually had two questions, but you already answered one, so I will move to the next one. I was wondering just a little bit that when you talk about the properties like modulatory effects of the vasoconstriction or vasodilatation otherwise, I wonder if those effects are independent from the endothelius, such as nitric oxide or something like that, and in case, if possible, that can be modulated pharmacologically to enhance those effects as a new antiparasitic.
So the answer is yes. We want to learn how to optimize the MSCs for the disease purpose that we're using them for. So, for example, for pain management, there's no question that when MSCs work for pain management, part of what they do is immunomodulation, because there's always inflammation associated with pain. So the minimum that MSCs do is decrease the inflammatory response. The second thing they do is to provide molecules that sit on opioid receptors. So the mechanism by which MSCs manage pain is not a single mechanism. It's multiple mechanisms. And that's, again, the people always ask, well, if you can find the molecule that the MSC is making, why don't you just make that a drug? And the answer is, it's never one molecule. It's never one aspect of the MSCs. It's a live cell, and the live cell is reacting to that microenvironment that it sees. And that's, I think, the genius of cell-based therapy, is that you get a cellular response. And so Diego and I fight about exosomes. I want live cells. I don't want just a piece of a cell. We have data that clearly shows that you need a live cell to make an antibacterial protein when it sees bacteria. The exosomes won't do that. So again, whether it's exosomes or it's MSCs, we need to make sure they're optimized for the therapeutic use that we're doing. So for me, for pain management, I definitely don't want exosomes. I want a cell that's going to give me the full range of response.
Brian Humphreys from Texas, Dr. Caplan.
I can understand your accent very well.
Well, thank you, and we understand y'all's.
Wait till I speak Spanish.
Yes, sir. You know, it's said that data, when organized, becomes information. Information, when filtered, becomes knowledge. And knowledge, when simplified, becomes wisdom. So we thank you for your wisdom this morning. My question is this, it's a very simple question. The lipogem, does that meet the FDA standards for minimal manipulation?
Yeah, so the answer is yes. And the bridge that's being crossed by the company is the issue of homologous use. Because it's not only minimal manipulation, but it's this crap about homologous use. So the FDA, in the filings by Lipogens, there was an initial filing and then a supplemental filing. The supplemental filing, the FDA agrees that it could be used for conditions of osteoarthritis. The mechanism that I suggested is the Caplan mechanism, not necessarily what the company would say publicly. The FDA has approved Lipogens as a fat transfer technology. And that's what it is. So again, cleaning up the fat preparation, and in particular for me, the reason why I like it is that saline wash that goes into the bag gets rid of all the monocytes that are in the preparation and all of the antigen presenting cells that have been liberated by the liposuction. I want to get rid of those because those are the ones that cause problems. And so for me, the company would say it's a cleaned up fat preparation. I would say hooray for that, because the plastic surgeons have been squirting liposuction material without cleaning it up in various parts of the body for 15, 20 years and getting away with it, and some of the patients react. So again, I like the engineering of the rig and the fact that there are now clinical trials going on to look at the therapeutic results.
No problems with fat embolus?
No problem with?
Fat embolus with intravenous use?
No.
Very
no.
good, thank you, sir.
No, it's been put sub-Q and into the knee in a variety of formats. And, you know, tell me about putting BMAC into your knee. It's non-homologous, right? Non-homologous, and for some people it has therapeutic outcomes. So there's a variety. The thing which people overinterpret, BMAC is not an MSC preparation. If you're 50 years old and you take a 10 ml aspirate, this is how many MSCs you have in that preparation. That's out of 500 million cells. It's not an MSC preparation. If there's a therapeutic outcome for which there's been reports, it ain't the MSCs that are doing it, it's some other cell. And in your bone marrow, you have professional secretory cells. All these hemopoietic cells are professional secretory cells. So who's the active agent? I don't know, and the people who are using it for sure don't know. So, but it ain't MSCs, count them, count them. So it's a really important point because there's many clinics in the United States and in Texas in particular and in Florida worse that provide stem cell preparations that are BMAC. It's not, and all of the verbiage on their websites are MSC verbiage. That's why I'm on this crusade to get people to stop calling those cells stem cells because they ain't. And that's, I think, the important thing. Cell-based therapy, if you can use BMAC or you can use lipogens and you get a therapeutic outcome, fabulous. It's the simplest, easiest technique to use. Culturing MSCs requires a GMP facility, requires a variety of assays for release of the cells and for their use therapeutically. It's a much more demanding technology. So if you could use fat transfer, or you can use BMAC, or you can use PRP, and you get a response profile from a patient, more power to you. But in the end, we're going to promote culture expanded, highly purified, specific MSCs treated in a specific way for a specific therapeutic outcome. That's what we're headed towards, and that's what we're trying to do. And Laura's lecture was perfect in telling you how a community in Italy is organizing itself to provide outcome data. And that's what's missing in the States. All these 500 or 700 clinics that do stem cell therapy, tell me how many report outcomes. Here, read the number. Read the number. If they all provided outcome analysis, we could go on the web and find out which ones provide therapeutic technologies. Even if a doc tells me, I'm going to give you a preparation, you have a 50% chance of responding, and you need to pay me $5,000 for that. But a 50-50 chance for $5,000, I'll pay the money. But I need to know it's 50-50. I need to know it's 50-50, and that's why we need outcome data. Yes, sir.
Buenas tardes. Solo una pregunta. ¿El nivel de citoquinas en el cuerpo puede ser el porcentaje de no respuesta y el porcentaje de respuesta en la terapia de MSCs?
So basically what he's asking is whether the discrimination between responders and non-responders can be explained by levels of cytokines circulating.
Well, so there's no answer for that question because we don't have good assays to identify responders and non-responders. But I'll give you one assay, which the orthopedic guys in the room will love this assay. So in the published clinical studies done for hyaluronic acid in osteoarthritic knees. So there's huge number of studies, and so I'm going to give you the conclusions, not the papers that report them. The placebo control is 2 mLs of saline versus 2 mLs of hyaluronic acid. So the standard procedure is 3 shots, 1 week apart. So the first shot, if you're a responder, about 30%, 35% are responders. So I'm only talking about responders. If you're a responder, you get 4 to 6 weeks from the first shot of hyaluronic acid, of pain relief. 2 mLs of saline, you get 4 to 6 weeks of pain relief from 2 mLs of saline. Hard to make a business on saline. And none of your insurance policies will pay the doctor for giving 2 mLs of saline. Second shot of hyaluronic acid, you can get 6 to 12 months of pain relief. Second shot of saline, 4 to 6 weeks. 4 to 6 weeks. That's a placebo effect. Wash the knee out of all the junk that's in it, and you get 4 to 6 weeks of pain relief. Third shot of hyaluronic acid, you can get 12 to 36 months of pain relief if you're a responder. Third shot of saline, 4 to 6 weeks. So that's an assay for a responder. If your patient pain goes away with 2 mLs of saline, first of all, the patient will say thank you. Second of all, that's a responder. That's a responder. So and if you go to the FDA and you say I have a responder assay which is 2 mLs of saline, they'll tell you you're crazy. So just tell them it's a Caplan assay, then they won't ignore you. But again, if you look at the data, so I'm a data guy. I look at the data and I say I can identify responders by 2 mLs of saline. So in my osteoarthritic knee, when I go to my orthopedic surgeon, I say, no thank you to hyaluronic acid, I want 2 mLs of saline. He says, Caplan, you're crazy. But again, how do you develop assays for responders versus non-responders? And that's what we need to do, and we need to find either in a blood sample, a synovial fluid sample. In these samples, we need to find molecules that we can assay that identify responders. Last question. He says last question. Yes,
Hola.
ma'am.
Buenos días. Buenas tardes ya. Doctor, mi pregunta sería, en la membrana el factor de histocompatibilidad o el receptor que muestra la célula, la MSC, comentaba al principio de la conferencia que eventualmente puede ser reconocida y yo me pregunto, después de que esto sucede, de que es reconocida, me imagino que se vienen una cascada de nuestro sistema inmunológico para reconocer esa célula. ¿Qué es lo que sucede con la célula cuando es reconocida o cuando por segunda ocasión se introducen las MSC? ¿Qué es lo que pasa? Me imagino que se despiertan varias respuestas del sistema inmunológico, células de defensa y inflamatorias, interleucinas, interferones, que ahí deben de empezar a trabajar. ¿Tienen ustedes estudios sobre esto o ha habido pacientes que presentan esta respuesta?
So Diego is going to answer your question.
So no, her question was basically if there's any presence of HLA-DR or HLA membrane in the membrane that would make them recognizable by the immune system of a host, and she's asking whether we have data. We have tons of data in my lab particularly, and in the
Well,
literature.
why don't you answer?
So, in Spanish. So, básicamente lo que sucede es que las MSCs carecen del HLA-DR o tipo 2, que es el complejo mayor de histocompatibilidad. Por tal motivo se pueden usar halogénicamente. No lo tienen, no lo presentan. Entonces, al entrar en el receptor, no van a ser reconocidas por las antigen presenting cells dendríticas como extrañas y no montan ningún tipo de respuesta. Eso se llaman inmunoevasivas. Sin embargo, y nosotros tenemos datos en el laboratorio que cuando tú estimulas MSCs con interferón gamma, que normalmente viene de monocitos, transitoriamente aumenta el HLA-DR hasta por 72 horas. Eso haría difícil un modelo halogénico en las siguientes 72 horas, pero única y exclusivamente después de la estimulación con interferón gamma. De resto, sin ningún tipo de estimulación, son totalmente inmunoevasivas porque la característica es ausencia de HLA-DR o tipo 2.